Hey everyone, and welcome to today's deep dive. We are so glad you're joining us.
Yeah, thanks for having me. It's a really exciting topic today.
It really is. So, usually, when we talk about a surgical procedure, there's this underlying assumption of like mechanical precision, almost like fixing an engine.
Right, like you take your car to the shop.
Exactly. You have a structural problem, the surgeon goes in, sews things up, and the issue is physically repaired. It
Yeah.
feels very binary, you know, broken and then fixed.
It's a comforting thought, certainly. I mean, we like to think of our bodies as machines that just need a new part or a tightened screw to get back to baseline.
Right. But then you step into the actual world of post-surgical recovery, and suddenly that mechanical illusion it shatters completely.
Oh, absolutely. The surgery itself might be a technical success, but the landscape it leaves behind, specifically the scar tissue, is incredibly complex. Healing is, well, it's a lot messier than surgery.
Messy is a good word for it. It's basically a biological battlefield. When the human body repairs a surgical site, it doesn't just put things back exactly as they were, neatly organized.
No, not at all. It aggressively lays down these dense, chaotic fibers to close the wound as fast as humanly possible.
And that chaotic biological battlefield is exactly what we are exploring today. We are looking at how doctors are taking a regenerative medicine technique and adapting it to treat severe structural scarring.
Right, because our specific mission for today's deep dive is to answer one highly technical but completely fascinating question.
Yes, exactly. We are asking, how does an O-shot injection technique adapt when treating a patient with structural scarring from a prior anterior colporrhea?
Which is, I mean, the implications of this specific adaptation are just staggering. It represents a massive paradigm shift in how we handle recovery.
Totally. And to get to the bottom of this, we are synthesizing data from a stack of incredible sources. We've got medical journals, clinical trial registries, including a double-blind trial on prolapse surgery, and standardized clinical protocols on platelet-rich plasma, or PRP, and the O-shot.
Yeah, the literature here is evolving rapidly. We are essentially bridging gynecology, cellular biology, and regenerative aesthetics into one highly specialized treatment protocol.
It's wild. And I promise, even if you aren't a surgeon, the way the body can literally be coaxed into dissolving its own scar tissue and regenerating nerve endings is an absolute aha moment just waiting to happen.
It really completely changes how we view chronic pain and tissue repair.
But before we can understand how doctors adapt this injection technique for a surgical scar, we first need to look at the baseline tools we're working with, right?
Right, we need to demystify platelet-rich plasma, or PRP.
Yeah, so how does that work at a baseline?
Well, we are dealing with the patient's own biological material. The foundation of this procedure relies on a very precise preparation process. So, blood is drawn from the patient's arm, much like a standard blood test, and then it's placed into a centrifuge to separate it out by density. But the calibration for this is incredibly strict.
Yeah, and the sources detail exactly what that calibration is. It isn't just, spinning it really fast. The protocol dictates the blood is spun at exactly 1784 G for precisely 5 minutes.
Exactly. And that G stands for relative centrifugal force. So it's not just about revolutions per minute, it's about the actual gravitational force being applied to those cells.
Wow.
Yeah,
Okay.
1784 G is the magic number because it's the exact amount of force required to pull the heavy red blood cells to the very bottom of the tube without crushing the delicate platelets we actually want to harvest.
That is so specific. So you're left with distinct layers based on molecular weight, right?
Yep.
You've got the red blood cells packed at the bottom, which we just discard for this. Then there's this very thin, highly concentrated middle band called the buffy coat, which holds white blood cells and platelets. And at the very top is the prize, the platelet-rich plasma.
Yes. That golden liquid at the top is what we are after. But it's really important to understand why it's so valuable. It contains over 20 different types of concentrated growth factors.
Okay, let's unpack this. Because calling it a supercharged healing serum doesn't quite capture the biology, does it?
Not really.
These growth factors aren't just nutrients. They're more like an architectural blueprint and a construction crew rolled into one, right? So PRP is basically a supercharged healing serum, custom made by your own body, delivered right to the tissues that need a reboot. You are delivering the exact chemical instructions for how the tissue should rebuild itself.
That is a much more accurate way to look at it. Yeah, they are cellular messengers.
Got it.
So in a standard baseline O-shot on a patient with no surgical history, the practitioner uses very fine needles to inject this blueprint directly into the clitoris and the upper anterior vaginal wall.
And what's the goal there?
The physiological goal is to stimulate angiogenesis, which is the formation of entirely new vascular networks, so new blood vessels, and to trigger tissue regeneration that improves overall nerve sensitivity.
But why target the anterior vaginal wall specifically? What is so important about that real estate?
Well, that vital real estate is exactly what gets sliced into when a patient experiences a specific type of pelvic organ prolapse.
Right.
When a surgeon repairs a cystocele, they are structurally altering the very nerve centers and tissues we are trying to rejuvenate with the O-shot.
Okay, let's define that. A cystocele is essentially a fallen or herniated bladder, right?
Precisely. The supportive tissues between a woman's bladder and vagina weaken over time or through trauma, and the bladder physically drops into the vaginal canal.
That sounds awful. So to fix that, the surgeon performs what's called an anterior colporrhaphy,
Yes, which is a transvaginal native tissue prolapse surgery.
meaning they have to make an incision right into that highly sensitive anterior vaginal wall, push the bladder back up, and then stitch the supportive tissue back together to hold it in place.
Which solves the mechanical failure, sure. The bladder is secure. But as we discussed at the top of the deep dive, the aftermath of that mechanical fix is a massive biological complication.
Right, the scar tissue.
Exactly. The body repairs that deep surgical incision by laying down thick, dense fibromuscular connective tissue.
And the sources say this structural scarring doesn't just happen on the surface, right? It extends deep into the pubovesical fascia.
Yes. The pubovesical fascia is that tough layer of connective tissue that acts like a hammock supporting the bladder.
And internal scar tissue is incredibly rigid. It has none of the elasticity of healthy vaginal tissue.
Not at all.
The sources note that for these patients, this deep scarring causes dyspareunia, which is severe pain during intercourse. The dense, chaotic fibers literally choke out the local nerve endings, causing numbness.
And it leads to tissue tethering.
Right, where the layers in the vaginal wall are basically glued together, losing all their natural mobility.
So you have a landscape that has been entirely re-engineered by trauma, which is why the standard O-shot protocol completely fails here.
Well, yeah, wait. If the O-shot is meant for healthy tissue rejuvenation, wouldn't a dense, tethered surgical scar physically block the PRP from spreading or make the injection incredibly painful and ineffective?
This raises an important question. Standard protocols assume you are injecting into relatively healthy, compliant mucosal tissue that can easily absorb a liquid volume.
Right, because if you try to inject liquid directly into a dense, unyielding block of scar tissue, the fluid has nowhere to go.
Well,
The hydraulic pressure alone would be agonizing, and the fluid would just pool or leak right back out.
exactly. So how do you deliver a liquid biological blueprint into a brick wall? When a massive surgical scar is present, the physical injection technique absolutely must adapt.
You can't just spot inject it.
Right, you cannot just use mucosal spotting, which is placing small amounts of fluid just under the surface lining. The mechanics of the needle have to completely change.
And looking at the clinical data, there are three major mechanical adaptations here. The first one fundamentally changes the geometry of the injection. I'm looking at clinical trial NCT 05731284, which explicitly states that in these post-surgical cases, the PRP must be injected in a systematic grid-like fashion.
Yes, the grid pattern is essential. Because the tissue is so dense and unpredictable, the provider has to mathematically map out the entire scarred area.
So they aren't just winging it.
Not at all. They systematically inject directly into the tough fibromuscular connective tissue of the anterior compartment. They are intentionally creating a widely distributed matrix of the PRP rather than dumping it in one localized spot.
So it forces the fluid to permeate the entire footprint of the scar.
Exactly.
But they aren't just creating a grid on the surface. That brings us to the second adaptation. They have to push the needles significantly deeper than a standard O-shot, right?
Yeah, they have to reach the pubovesical fascia itself. This is documented heavily in a remarkable 48-month study by Atilgan et al., which involved 56 women.
Oh wow, 48 months is a long study.
It is, and the injections in that study deliberately target that deep fascial layer. The reasoning here is crucial. The goal isn't just to treat the superficial surface pain.
Right.
By delivering the growth factors deep into the fascia, they are actively reinforcing the pelvic support structures to prevent the cystocele, the fallen bladder, from recurring.
Okay, so we have a geometric grid pattern and a much deeper targeted depth right into the fascia. But the third adaptation is what actually solves the problem of the rigid, tethered tissue blocking the fluid.
Ah,
They
yes.
borrow a technique from dermatology and plastic surgery called subcutaneous subcision.
Subcision relies entirely on physical mechanical force.
That sounds incredibly intense, honestly. The
Right.
practitioner places the needle subcutaneously, meaning horizontally just below the skin and the scar tissue layer itself, right?
Yes.
But before they push the plunger to inject the PRP, they physically move the needle back and forth in a fanning motion.
Exactly. They are using the sharp bevel of the needle to literally cut and shear the fibrous bands that are tethering the healthy tissue down to the deeper structures.
So they are mechanically breaking up the scar architecture from the inside out.
Yes, and it creates a physical void. By breaking those tethered bands, they instantly open up a pocket of space underneath the scar, and then they flood that newly opened space with the PRP.
Wow. It's like, so instead of just watering the top of a dead lawn, we're installing a grid-like sprinkler system underneath the hard-packed scarred dirt to break it up and nourish it from below.
That is a brilliant way to visualize it. You are releasing the mechanical tension first, which allows the biological fertilizer to actually penetrate and go to work.
So we know how the needle adapts mechanically to bypass the scar, but what's actually happening at the cellular level once that grid of PRP is sitting beneath the tissue, like how does a scar actually dissolve?
This is where the biological mechanisms are truly fascinating. Once the PRP is in place, those 20-plus growth factors act like a cellular demolition and construction crew.
So what are the main factors at play here?
We are specifically looking at proteins like VEGF, vascular endothelial growth factor, PDGF, platelet-derived growth factor, and TGF-B, transforming growth factor beta.
And these aren't just like passive nutrients sitting there, they actively command the surrounding cells.
Yes, they act as a highly coordinated communication network. When they saturate the scarred area, they immediately signal the local immune system to dial down chronic inflammation.
Yeah.
They encourage healthy cell proliferation. But most importantly for our surgical patient, factors like TGF-beta actually send a chemical signal to the fibroblasts.
And fibroblasts are basically the body's primary builders, right? They are the cells that manufacture connective tissue.
Precisely. The TGF-beta signals those fibroblasts to stop producing the rigid, chaotic collagen types that make up a scar, and instead start secreting enzymes that literally break down and soften the old, stiff scar matrix.
Wait, really? So if TGF-beta is signaling the body to stop producing rigid collagen and dissolve the old matrix, and VEGF is simultaneously commanding the creation of new blood vessels, then the body is literally replacing the scar with a living vascular network.
Exactly.
It is dissolving its own gristle and replacing it with healthy tissue.
It is reprogramming the scar to behave like healthy mucosa again. And we have visual evidence of how powerful this cellular signaling is. The sources reference an in vitro study by Metal et al., which provides a stunning look at this interaction.
Right, the MESH study. And since it was in vitro, it means they observed this in a laboratory environment outside the human body, so they could clearly see the cellular mechanics.
Right. They took living vaginal fibroblasts and observed how they interacted with synthetic surgical vaginal meshes.
And synthetic meshes are notoriously tricky in pelvic surgery, aren't they?
No, very, because the body recognizes them as a foreign object. The natural immune response is to attack it, encapsulate it, and scar heavily around it.
But Metal's team found that when they coated those synthetic meshes with PRP, the living vaginal fibroblasts attached to them significantly better. The PRP fundamentally changed the biological reaction.
The PRP acted as a biological bridge. It facilitated immediate cellular integration.
So in the body, this means PRP helps living, healthy cells grab onto and remodel the surgical area.
Yes, whether it's native tissue or a mesh, it breaks down the pathogenic scar tissue and remodels the entire area with healthy supportive fibers.
Which brings us back to you, the listener, because you might be wondering why this highly specific vaginal surgery matters to you if you are never going to experience a bladder prolapse.
Right.
But the reason this is so groundbreaking is that it proves a profound medical reality. The body's natural healing factors can be weaponized to reverse chronic pain and surgical trauma anywhere.
And if we look at the clinical outcomes, the data is just undeniable. Let's look back at that 48-month Atilgan study we mentioned. They tracked the long-term success of these patients.
Oh, the reoperation rates?
Yeah. The women who underwent their cystocell repair surgery without any PRP intervention had a reoperation rate of 17.8%. Their prolapse eventually failed again in nearly a fifth of the cases.
Wow.
But the group that received the deep fascial PRP injections alongside their surgery, their reoperation rate plummeted to just 3.5%.
That is a staggering statistical drop,
Yeah.
17.8% down to 3.5%. It proves that it doesn't just feel better, it structurally heals the prolapse repair, making it highly resilient over a 4-year period.
It structurally heals the pelvic floor, absolutely. But, we do have to address the clinical reality of performing this adapted procedure.
Yeah, because re-engineering surgical scars with needles mechanically shearing them sounds incredibly intense.
It requires extreme caution, and pain management is a critical pillar of this protocol.
Right, because scarred tissue often has altered, hyperreactive nerve endings. It can be a source of severe neuropathic pain. You
Right.
can't just use like an over-the-counter numbing cream and expect the patient to tolerate subcutaneous subcision.
Definitely not. The clinical standards mandate a highly potent compounded topical anesthetic. It is known as the 2088 protocol.
The 2088 protocol, okay,
Yeah.
so the sources break that down as 20% benzocaine, 8% lidocaine, and 8% tetracaine. Why those three specific agents together?
Well, it's about layering the anesthetic effect. Benzocaine provides a very rapid onset of surface numbing. Lidocaine penetrates deeper into the tissue for localized anesthesia.
Okay.
And tetracaine is a long-acting agent that ensures the numbness persists throughout the mechanical shearing of the subcision process.
But just applying it isn't enough, is it? The protocol strictly demands this cream be left on a treatment area for a full 20 minutes prior to the first injection.
Which makes sense. You have to give those chemical agents time to fully permeate that dense fibromuscular tissue before you start introducing a needle.
And once the area is anesthetized, the physical injection requires absolute anatomical precision. I mean, the providers working in a landscape where the normal anatomical landmarks have been totally shifted and distorted by the prior prolapse surgery.
They cannot inject blindly. What's fascinating here is the absolute necessity for precision. Because the tissue is altered by prior surgery, injecting too much volume is dangerous.
So what are the parameters?
The protocol demands small, discrete aliquots, meaning tiny controlled doses, using very fine 30 to 32 gauge needles.
Because if you push too much fluid into an unyielding scar too quickly, you risk a massive tissue tension, excruciating pain, or physically tearing the tissue planes.
Exactly. And the altered anatomy brings up the most critical safety protocol of all, which is avoiding the vascular network.
Right, the worst case scenario. The sources highlight a sobering case study that underscores the absolute razor-edge margin of error here. Now, this case involved a facial PRP injection for aesthetics, not a vaginal O-shot, but the physiological risks and the required needle protocols are identical.
Yeah, the case involves an unlicensed practitioner injecting PRP into a patient's glabella, which is the space right between the eyebrows.
And because the practitioner lacked a deep understanding of vascular anatomy and failed to follow basic injection protocols, they accidentally injected the pressurized PRP clot directly into an artery.
And injecting into a pressurized vessel causes retrograde flow.
Meaning it goes backwards?
Yes. The pressure from the syringe forced the platelet clot backward against the normal flow of blood up the artery. It traveled into the cerebral circulation and resulted in an occlusion of the ophthalmic artery and regions of the middle cerebral artery.
Oh my God.
The patient suffered an irreversible cerebral infarct and permanent blindness.
That is horrifying. But it underscores exactly why this cannot be taken lightly. A millimeter difference in depth means the fluid goes into a blood vessel instead of the fascial tissue.
It is the ultimate cautionary tale for regenerative medicine. Whether you are treating a forehead wrinkle or a scarred anterior vaginal wall, the provider must intimately understand the local vascular anatomy. And they absolutely must aspirate the needle, which means pulling back slightly on the plunger once the needle's in the tissue. If blood flashes into the syringe, they know they are in a vessel and must abort the injection.
So aspiration is a non-negotiable safety step before injecting a single drop of PRP.
Completely non-negotiable.
So let's zoom out and look at the whole picture here. We
Yeah.
started with a highly specific, very painful complication, a dense, unyielding fibromuscular scar left in the wake of a bladder prolapse surgery.
And we looked at how that tough tissue chokes out nerves and causes severe tethering.
Right. And then we discovered how medical protocols have to adapt mechanically and biologically. The standard O-shot transforms to a highly precise, grid-like delivery system using subcutaneous subcision to physically shear the scar tissue.
Using a heavy-duty 2088 anesthetic protocol to manage the altered nerves.
Yep. And a centrifuge calibrated to exactly 1784 joules, so doctors can deliver a concentrated blueprint of growth factors deep into the pubovesical fascia.
And those factors command the body's fibroblasts to dissolve the old scar and rebuild a healthy vascular network.
ultimately dropping the surgical failure rate from nearly 18% down to just 3.5%.
It perfectly illustrates how true regenerative medicine doesn't just patch a problem, it actively instructs the body's architecture to rebuild itself from the cellular level up.
Which is just incredible. And it leaves you, our listener, with a final thought to mull over. If an injection of your own concentrated blood can reprogram a rigid, traumatized surgical scar to literally dissolve itself and behave like healthy, sensitive tissue again, what does this mean for the future of surgery as a whole?
It's a great question.
Will we one day look back at our current era and consider any mechanical operation fundamentally incomplete unless it finishes with a customized cellular injection? Like, maybe the ultimate goal of surgical science isn't just to make the cleanest cut, but to program the body so a scar never forms in the first place.
That is definitely something to think about.
It really is. Well, thank you so much for joining us on this deep dive.
Thanks for having me. It was a great conversation.
Take care, everyone. We'll catch you on the next one.